A soldier lies on a stretcher. His leg is gone, completely gone, severed just above the knee by shrapnel. He's not screaming anymore. He screamed for the first hour. Now he's beyond screaming. He's somewhere else. Psychologically, he's already dead. A medic approaches, not a doctor, not even a trained nurse, a soldier who received basic medical training weeks ago. The medic looks at the wound. He knows what needs to happen. He knows it will likely kill the soldier, but infection will definitely kill him. He reaches for the morphine. There is none. It ran out an hour ago. He reaches for whiskey. There is plenty of that. The medic pours whiskey on the wound. The soldier finally screams again. At least now he's feeling something. This wasn't the exception in World War II. This was the rule. Medical treatment during World War II wasn't medicine. It was survival theater. A desperate attempt to keep soldiers alive long enough to fight again. Today, we're going to explore 15 harsh realities of medical treatment during World War II. From amputation without anesthesia to infection that became the primary killer, we'll discover exactly what soldiers actually experienced. The truth is disturbing. It's also absolutely necessary to understand. Reason 15. Morphine shortages and inadequate pain management. Suffering without relief. Morphine was the primary painkiller available during World War II. But there was never enough. Supplies would run out, soldiers would be wounded. Morphine would not be available. A soldier with a shattered leg would have to endure amputation without anesthesia or painkillers. Just conscious, aware of everything. The psychological trauma of this experience was incalculable. Surgeons developed rapid amputation techniques specifically to minimize the time a conscious patient would suffer. They would work as fast as possible, racing against the limit of human consciousness. Some soldiers would lose consciousness from pain and shock before the amputation was complete. This was actually fortunate. At least they stopped feeling something. Others would remain conscious through the entire procedure. They would remember every moment, every sensation, every sound of the saw cutting through bone. The psychological consequences lasted lifetimes. Survivors reported that the memory of amputation without adequate anesthesia was worse than the loss of the limb itself. Pain without relief is torture. In World War II, this torture was routine. Reason 14. Battlefield triage and impossible decisions. Who gets to live? Medics in combat situations had to make decisions that no person should have to make. They had limited resources, limited time, limited supplies. Faced with multiple wounded soldiers, they had to decide who would receive treatment and who would be left to die. This was called triage. It was necessary. It was also psychologically devastating for the medics performing it. A soldier with a survivable wound would receive treatment. A soldier with a fatal wound would be marked as expectant and left aside to die. But determining which wounds were fatal and which were survivable required judgment that was often wrong. Medics would mark a soldier as expectant, believing he would die soon. That soldier would sometimes remain conscious for hours, aware that he had been written off, aware that he was going to die. Other soldiers, marked as salvageable, would die from complications that couldn't be anticipated. The medics would carry guilt for the rest of their lives. They had played God, and they had made mistakes. Reason 13. Infection. As the primary killer, the invisible enemy. Bacterial infection was the primary cause of death in World War II combat casualties, not the initial wounds. Infection. Antibiotics existed, but penicillin was in short supply and was reserved for the most critical cases. Most soldiers with serious wounds would develop infections. The infection would start small, a fever, redness around the wound, gradually escalating into sepsis. Once sepsis developed, there was almost no treatment available. The soldier would deteriorate rapidly. Surgeons would perform amputations specifically to remove infected tissue and prevent sepsis from spreading. But even this desperate measure often failed. Soldiers would watch their limbs die, literally. The tissue would turn black, the smell would become unbearable, and there was nothing that could be done except wait for the spreading infection to eventually reach the heart and kill the soldier. This process could take days or weeks. The soldier would remain conscious through most of it. Infection was a slow, agonizing death, and it was the fate of most seriously wounded soldiers. Reason 12. Lack of blood transfusion availability. Bleeding out on the operating table. Blood transfusions existed, but they were rarely available in combat situations. A soldier with severe bleeding wounds would lose consciousness from blood loss. If he didn't receive a transfusion within minutes, he would die. Field hospitals tried to maintain blood supplies, but the logistics were impossible. Blood had to be refrigerated. It had to be transported without breaking. It had to be typed and matched. In the chaos of combat, these requirements were often impossible to meet. Soldiers would be brought to field hospitals having lost critical amounts of blood. Surgeons would attempt emergency transfusions, but if the blood wasn't immediately available, the soldier would die on the operating table. Surgeons became expert at recognizing the moment when a soldier was unsalvageable. The moment when blood loss had been too severe, they would stop operating, they would step back, and they would allow the soldier to die. The alternative was to perform emergency surgery, knowing the patient would certainly die anyway. This served no purpose except to traumatize the surgical team. Reason 11. Amputation rates and permanent disability. Losing parts of yourself. Amputation was common in World War II. Explosive wounds would destroy limbs. Infection would necessitate removal. Gangrene would require surgical removal of dying tissue. A soldier could survive his wounds, but he would lose a limb in the process. The psychological adjustment to losing a limb was devastating. Soldiers had trained their entire lives with their bodies intact. They had played sports, they had worked with their hands, they had walked. Suddenly, they couldn't do any of these things. Prosthetics existed, but they were primitive. They didn't restore function. They provided basic mobility at best. A soldier who lost both legs would spend the rest of his life in a wheelchair. In the 1940s, this meant permanent institutionalization. Soldiers would contemplate suicide rather than return to civilian life as amputees. Some did attempt suicide. Hospital wards would have to be monitored constantly to prevent soldiers from killing themselves. The physicians could save lives, but they couldn't save the quality of those lives. A survivor who was an amputee wasn't actually surviving. He was existing. Reason 10. Anesthesia complications and overdose. Falling asleep and never waking. Anesthesia during World War II was primitive and dangerous. The primary anesthetic was ether. It was effective, but it was toxic, and it was administered by people with minimal training. Anesthesiologists were scarce. Most field hospitals didn't have anyone with formal anesthesia training. Anesthesia was administered by nurses or corpsmen who had received brief instruction. Dosing was often guesswork. Too little, and the patient would wake during surgery. Too much, and the patient would stop breathing. Complications were common. Soldiers would go into anesthesia for what should have been a routine procedure and simply never wake up. Aspiration was a common complication. The patient's stomach contents would enter the lungs during anesthesia. The patient would essentially drown in his own vomit. This could happen either during surgery or immediately after, as the patient was awakening. Surgeons learned to accept anesthesia-related deaths as an unavoidable consequence of the medical situation. They couldn't have trained anesthesiologists. They couldn't have sophisticated anesthesia equipment. They had ether. They had untrained personnel, and people died because of it. Reason 9. Surgical equipment limitations. Performing complex surgery with primitive tools. Surgical equipment in field hospitals was minimal. In established military hospitals, equipment was better. But field hospitals operating close to the combat zone had very limited resources. Surgeons performed amputations with bone saws that would be considered crude by modern standards. They performed emergency surgery with instruments that were inadequate for the complexity of the procedures required. Sterility was difficult to maintain. Infections would develop from surgical contamination as often as from the original wound. A surgeon performing emergency abdominal surgery in a field hospital in 1943 was working with equipment that would be considered archaic today. Yet they were attempting procedures that required precision and sophistication. It's remarkable that any soldiers survived at all. Reason 8. Psychological trauma and untreated mental illness. Minds breaking faster than bodies. Battle shock, shell shock, combat fatigue. Soldiers had many names for what we now recognize as PTSD, but there was no treatment for it, no understanding of it, no recognition that it was a real medical condition. A soldier who had experienced severe combat trauma would often be returned to combat. The assumption was that he simply needed to toughen up. That continued combat exposure would somehow normalize the trauma. In reality, this made things worse. Soldiers would break psychologically. They would become catatonic. They would attempt suicide. They would become violent. And they would be labeled as malingerers, cowards, weak. There were no psychiatrists in field hospitals. Mental health treatment was essentially non-existent. Soldiers experiencing severe psychological trauma had nowhere to go. No support, no treatment. Many would commit suicide while in the hospital, considered wounded and helpless by everyone except themselves. Reason 7. Hygiene conditions and disease. Infected wounds in unsanitary environments. Field hospitals operated in difficult conditions. Sanitation was challenging. Water supply was limited. Sewage systems were primitive. Soldiers with open wounds were placed in environments that were conducive to infection. Flies would lay eggs in open wounds. Soldiers would develop maggot infestations. Surprisingly, maggot infestations sometimes actually helped. The maggots would consume infected tissue, essentially providing debridement, but most contamination led to severe infections. Soldiers would develop dysentery from the unsanitary conditions. This would lead to dehydration and death in already weakened soldiers. The hospitals themselves became sources of infection. A soldier who survived his initial wounds could easily die from an infection acquired in the hospital. Reason 6. Amputation techniques and complications. Removing limbs without certainty. Amputation was sometimes necessary, but determining exactly where to amputate was difficult. If surgeons amputated too high, they'd remove healthy tissue unnecessarily. If they amputated too low, infection could recur in the remaining limb. The decision was made based on visual inspection of tissue viability, but tissue death progressed faster than it could be visually detected. Surgeons would amputate what they thought was the boundary between living and dead tissue. Then, after surgery, the remaining limb would develop infection. The amputation would have to be repeated, higher up. A soldier could undergo multiple amputations as infection repeatedly necessitated higher removal. Eventually, a soldier who had lost a foot would have lost a calf, then a thigh, then a hip. What had started as a survivable wound became increasingly severe with each necessary amputation. Reason 5. Shock and cardiovascular collapse. The body shutting down. Severe trauma causes shock. The body's systems begin to fail due to trauma, blood loss, and psychological stress. Shock can be fatal. A soldier in severe shock can die even if his wounds are survivable. Treatment for shock requires fluids, rest, and time. The soldier needs to recover physiologically before surgery can be attempted. But in combat situations, there was often no time. Surgeons would be presented with soldiers in profound shock. They would have to decide, attempt surgery immediately, or wait for the patient to stabilize. Waiting meant the soldier might die from his wounds before stabilizing. Operating meant the patient might not survive anesthesia or surgery. It was a choice between two types of death. Many surgeons chose to operate immediately. At least there was a chance. Waiting guaranteed nothing. Reason 4. Insufficient trained medical personnel. Practicing medicine without adequate training. Medical training takes years, but the military needed medical personnel immediately. Soldiers received brief training and were assigned to medical duties they weren't equipped to perform. A medic with 3 weeks of training would be responsible for emergency field surgery. A corpsman with minimal experience would be managing trauma resuscitation. Mistakes were inevitable. Surgeons would work with surgical nurses who had never formally trained as surgical nurses. The gap between what needed to be done and what the available personnel could actually do was enormous. Many soldiers died because their medical care was provided by people who didn't have the training to provide adequate care. It's not that these personnel lacked dedication. They simply lacked expertise. Reason 3. Gangrene and tissue death. Watching your body die piecemeal. Gas gangrene was a particular horror. A soldier would receive a wound contaminated with certain bacteria. These bacteria would produce gas inside the muscle tissue. The muscle would die. The tissue would turn black. The smell would be overwhelming. The only treatment was amputation, and it had to happen quickly, before the gangrene spread to vital organs. A soldier with gas gangrene would experience rapidly advancing tissue death. The gangrene would progress from the foot to the calf to the thigh to the hip within days. Each day, the surgical team would have to consider, does the patient have enough healthy tissue left to save his life? Eventually, The answer would be no. The soldier would die from spreading gangrene that amputation couldn't stop. Reason 2. Lack of prophylactic antibiotics. Knowing the infection is coming. Penicillin existed during World War II, but it was precious and limited. Most soldiers with serious wounds would not receive prophylactic antibiotics. Surgeons would know, with certainty, that infection would develop. They would know that untreated infection would likely be fatal, and they would be unable to prevent it because antibiotics simply weren't available. It was like watching someone who was drowning and having a rope but choosing not to throw it. Except the choice wasn't emotional. It was logistical. The rope, penicillin, didn't exist in sufficient quantity. Soldiers would be told that infection was likely, that they should watch for signs of fever, that they should return to the hospital if they developed symptoms. Most would develop infections. Most would either die or lose limbs to amputation. The tragedy was that the cure existed, but it wasn't available. Reason 1. The reality of survival. Living with permanent consequences. Here's the truth that medical histories often gloss over. Surviving World War II wounds was often worse than dying from them. A soldier who survived amputation would spend the rest of his life as an amputee. A soldier who survived infection would often have permanent organ damage. A soldier who survived psychological trauma would often have lifelong mental health problems. The medical system could save lives, but it couldn't restore lives to what they were before. Survivors would return home to a society unprepared to help them. Prosthetics were primitive. Mental health support didn't exist. Disability benefits were minimal. A soldier who had lost both legs would face decades of institutionalization or struggle. The success of medical treatment was often just prolonging suffering. Surgeons saved lives, knowing that those lives would be permanently damaged, knowing that their patients would face a lifetime of disability and pain. But they did it anyway, because the alternative was death.